Hey, everybody. Welcome back to Autism Confidential, the podcast from the National Council on Severe Autism. I am Jill Escher, and I am your host today. And yeah, I'm a little bit informal today. I just got back from pickleball. So if there are any listeners out there who want to take me on a pickleball, please email us at info@ncsautism.org. You will have to come to the South Bay of the Bay Area, however. Yeah, pickleball. I'm one of the middle-aged people in America who has taken up pickleball. Anyway, we are back. I'm very happy to say with part 2 of our interview about dental care for patients with autism. Again, a very, very hot topic among all our families. Everybody has a dental story to tell, and it's usually not a pretty dental story, in our community. So we have, of course, the very eminent Dr. Allen Wong with us again. Welcome back, Dr. Wong.
Well, thank you, Jill. Thanks for having me back.
Now, Dr. Wong is Director of Advanced Education in General Dentistry in the Residency Program at University of the Pacific, which is here in the SF Bay Area. He teaches dentistry for special healthcare needs and hospital dentistry as well. And in our first episode, which came out last week, Dr. Wong and I really focused on issues around like tooth hygiene, dental care, oral hygiene, visits to the dentist, all of that. So I strongly recommend that you listen to that part before you listen to this part, because today we're switching our focus to issues that are a little more systemic, which is, and a lot of you know this, it can be very difficult for our families to access dental care for their special needs child or adult. And then there are also other issues that really complicate matters like anesthesia, and that complicate them not only in terms of clinical care, but in terms of how much it costs. So Dr. Wong, you have had a lot of experience working with these families who have children and adults with autism and other special needs. Has it been your experience that these families have a harder time accessing dental care than your average patient?
Absolutely. And if you looked at part one kind of identifies the problem. Unfortunately, at a certain age, developmental disability of all sorts doesn't end. It continues on and gets more complicated. And so the eventuality basically is it's not only harder to get dental care or medical care, but the medical care and dental care becomes more complicated.
Yeah, and for our kids, and we did reference this in the last one. It's sometimes as they get older and stronger, bigger, and they age out of the pediatric dentists, it's hard to find practitioners, right, who will take a patient with challenging behaviors. So that's number one. But number two is insurance, right? If you're on public insurance, sometimes it's my understanding, and I don't know what it's like. We reach all 50 states here on this podcast. But I know in California, it can take years. I'm saying years for somebody on Medi-Cal, for example, to get the dental care that they need. And I'm wondering if we can talk about those insurance barriers as well. Do you deal with those insurance type issues?
Yes, very much so.
Okay.
The sad part, like you say, you're in the different states, you're in 50 different states, and there are probably 30 or 40 different programs.
Yeah.
Each state is unique in itself. California, fortunately, does cover certain things for patients with special health care needs, but in other states, there's no treatment. There's really just extraction, if you will, and that's not treatment at all. That's just is sad. So until we can be more equitable, countrywide, statewide, without boundaries. That's our goal. Our goal is to make sure that our populations, whether be it autism or any kind of developmental disabilities, that they all have fair and equal treatment in every state and every area with the same amount of coverage. So that's our ultimate goal.
Wow. So what you're saying that is, so let's say an adult with autism who only has public insurance and has no private insurance, which is common, right? That's typically the case. They'll go in and they'll have a cavity, right here in their back tooth.
Right.
The answer is that they'll have insurance to extract the tooth, but not for any other form of care.
That's correct. In some areas, that's what it is. That's kind of the injustice. And that's if you find someone who takes that program. And unfortunately, and there's not a lot of people that are seeing the Medicaid type programs. It's very challenging already.
So most practitioners just won't see Medicaid patients, most dental practitioners.
Correct.
In California, it's my understanding, and correct me if I'm wrong, that is it Denti-Cal?
Yeah, they call it Medi-Cal of California, which was formerly known as Denti-Cal.
Denti-Cal. Is it Denti-Cal does on paper cover these treatments, but it's a matter of actually finding people to do the work. Is that part of the issue?
Yes.
Tell me in California what you're seeing.
Okay, so what I'm seeing, I fortunately teach at a dental school, and we do see the Medi-Cal dental population. And fortunately, because it's a dental school, we do have some emphasis programs on prevention, whereas in the private sector, seeing Denti-Cal, you don't. There's not such an emphasis, unfortunately. Sometimes we sort of spend $1 to save a dime, and people are so afraid of fraud, waste, and abuse that they don't want to cover anything due to the fear of abuse, right? So that's where we are in California. So ordinarily, for most private practitioners, you have to pre-authorize the work that you want to do. And then a few weeks later, you get the authorization to do it or not do it. Now, the challenge is, how do you know what you're going to do on someone who may or may not be able to take x-rays on? So the rub is that a lot of times things don't get pre-authorized because a patient comes to the office, they don't tolerate x-rays. And if you don't tolerate x-rays, we can't do the exam. And if you can't do the exam, you can't get the authorization to do the work. So it's kind of a lot of hoops to jump. And a lot of private practices just aren't set up to do that because there's no compensation for all that effort that's being done.
All that extra effort. So there are practitioners who say, well, if you just private pay me, I'll do it.
That's true.
Right.
Right.
And so we took our son to a dentist who we private paid. But we have private insurance for him. He's still covered. I think that covered some part of it.
Right.
But we had to pay out of pocket for most of the care and for all the anesthesia.
Right.
And is that common? Is there any way to get anesthesia covered?
Technically, the Medi-Cal system, or Denti-Cal, we'll call it, does cover for anesthesia when necessary. Now, then you have to find a dentist who is affiliated with a hospital that will allow them to bring the patient to that hospital. Since the pandemic, it's made it very challenging for people who have hospital privileges to schedule cases such as this. Because not only is dentistry not covered, a lot of times medicine is covered at such a low rate. And when I mean a low rate, it's dramatically low. For an admission to the hospital to have an outpatient procedure, for instance, last year, for instance, someone going into the hospital may charge or may only get compensated $200 for that admission, and that's supposed to pay for the room and
Oh my God.
supplies. And the anesthesiologist might get paid $150.
Oh, no anesthesiologist is going to do that.
Well, that's exactly right. That's exactly right.
Yeah.
So if you think that, there's no incentive for dentistry, there's no incentive for medicine either, because they have to pay their staff and their equipment and maintenance and all that sort of stuff. So there's a de-incentivization in seeing patients in the hospital.
Yeah.
And the whole team is not very much rewarded for doing the right thing.
Oh my gosh. I have heard of cases. So here in California, I'm sorry that we have 50 states and it's everything's different in all 50 states. Can't do 50 podcasts, but here in California, we do have regional centers. And I have heard of the regional centers stepping in and under regional center covered services, some dental care can be provided when they are the payer of last resort. They are considered the payer of last resort. So if everything else fails in terms of insurance and private funding, then they'll actually pay. I don't know if you've ever come across that,
Yes.
but there's
Yeah.
a little bit of a safety net here.
A very small safety net for those who just meet that criteria for hospital dentistry,
Right.
but not always for general dentistry.
Okay.
So ordinarily, Medi-Cal or Denti-Cal rather covers most of this population. So the regional centers will cover what's not covered, basically. So if it's covered, it's covered, and you just have to accept the fee that they reimburse for, which is very, very low. So
what are the workarounds? I mean,
Okay.
are there clinics like that University of Pacific holds? Are there other public clinics? Is there a philanthropist here who's saying like, I'll pay for your dental care? Like,
Well,
what are workarounds?
Well, first of all, the philosophy shouldn't be that equitable care shouldn't be charitable care. It shouldn't be, oh, someone's paying for this all the time. We should be able to do this if it's done properly. So we have to rethink that model. There is some hope because I think I mentioned last time that there are some new codes that are coming out that might help influence some practitioners where you're getting paid for time or extra time needed. It's a D9920 code for kind of behavioral management, if you will, and it allows the dentist to be able to charge for extra time necessary for whether someone has an emotional, physical, psychological need for adjustment. So when you're desensitizing and you do a procedure, I not only can I charge for the procedure, I can charge for that little extra time that it took to do something. So that's sort of a crack in the door that gives us hope that maybe that you might be able to be compensated for the time utilized to appropriately help a patient get accustomed to the office. Because it's an office is a very scary environment, first of all, but a lot of times when a patient is comfortable, it's no big deal. Once they're comfortable, they become really great patients. And a lot of my patients would come in and the first time they wouldn't want to sit in the chair. After a couple of appointments, they can work my chair, they can bring it up and down, they know how to use my squirt gun. They're very cooperative if you allow them to succeed. But back then we didn't have that special code. We just sort of incorporated that as part of our doing business kind of sort of model.
And that code, is that for all for public and private insurance? I'm sorry.
Yeah, actually, Denti-Cal, Medi-Cal Dental does cover it if you properly document it. So that gives me hope. It's also done in some private insurances too, where they have behavioral guidance codes too.
Interesting.
That allows either the dental team or even the behaviorist to work with the population. So there are some avenues of hope. I don't think there's enough clinics in the world to facilitate everyone, and that's not the answer. The answer really is to provide care in the neighborhood setting by incentivizing people to do the right thing and be paid properly, and incentivize the right thing. Recently, we, the American Academy of Developmental Medicine and Dentistry, have been working with the National Council on Disability on this huge report that just came out last month. I made a reference to it last time, and I'll send you the link that maybe you can post later on. And ask the question and surveyed thousands of practitioners. One is, if you see Medicaid, great. What's making you see them? If you saw Medicaid and don't see the population anymore, why did you leave? And more importantly, if you were to see Medicaid, what would incentivize you to see that population now? So it surveyed a lot of really good things. And the information that came out is really kind of important to know as we move forward. We always think it's reimbursement, but that's not always the answer.
What
Uh,
is?
Well, that's a teaser. You have to read the report.
Yeah,
No. It's only part of the answer.
Mhm.
A lot of things are, there are some barriers that need to be addressed, and the barriers of transportation, for instance. When a person turns a certain age, they don't have supports for transportation or whatnot, and it becomes very complicated. So often the patient doesn't show up for their appointment, they're late for their appointment, and therefore the practice says, we're not going to see them again. They've missed 2 appointments, or they don't care to come. So we have to address certain other barriers beyond that of access to care. So with the few that we have, we need to treat them properly and make sure we give all the tools for success. But the focus should be on the prevention. And I mentioned a little bit more prevention last time, is we can't do hospital dentistry and work our way out of this problem. We have to stop the insanity, which is the lack of prevention. If we invested if we invested a fraction amount that we spend in hospital dentistry into prevention, we can avoid a lot of hospital dentistry. Period.
Maybe it should be on every autistic kid's IEP at school, that they start the day with tooth hygiene and they end the day with tooth hygiene. I mean, seriously, I think it's
No.
that important for this population, to avoid
Right.
invasive dental care if they possibly can.
Right. And
Yeah.
I think I alluded last time that there's a new standard in dentistry that all dental schools must graduate students who are competent in taking care of people with special health care needs, and not only knowing about it, but actually treating them. And part of that is focusing on the prevention part. And we know they're at their risk for cavities. So we have to combat those risks by educating the patient and the caregiver on what is causing the cavities. It's not just about brushing and flossing, it's not just about sugar. It's about the chemistry that's in the mouth and being aware of it, and then doing things that we can counterbalance some of the negative effects earlier. And I think I mentioned silver diamine fluoride last time.
Yeah.
SDF. And that is a key player in part of this answer to the question. And it has saved many people from going to the hospital. So if we can implement these very inexpensive strategies early in the transition of the teenager and the adolescent, as they become adults and the teeth get stronger and harder, and that they don't have to have injections and they don't have to have that that kind of invasive kind of surgical procedure, and they're able to just paint things on and stop things from getting worse, then they can build a relationship with the dental office that is more conducive towards a friendly environment. Right now, they come to us and they're in pain and they're scared, and that's just no way to have a relationship with a healthcare team.
Well, I want to switch the topic to anesthesia for a minute.
Sure.
So anesthesia is a big issue because our kids very, very often need to go under general anesthesia as opposed to just local anesthesia, which is the case with, most of us, right? Most of us can just take Novocaine and, grin and bear it. But, for my son, that would be, for example, just impossible.
Right.
So he's had to undergo anesthesia in dental offices a couple times, and they have these anesthesiologists who are anesthesiologists on the go, right? They bring their vaporizers and all their equipment with them, and all their monitoring equipment. I mean, it's just amazing. They'll set up shop right there in the dentist's office. And then the alternative to that, as you said, is hospital dentistry, where you basically are in kind of more like an operating room situation. So what's your family are trying to figure out, what to do for your kid? Is it really dependent on what the dentist wants? How do you figure out the best course for anesthesia for your child? Or do you say, hey, if I give him enough of a sedative, you can use local, right? Rather than putting him under, because putting him under that's a big deal. It's also very expensive. How does a family go about making a decision about dental anesthesia?
Oh, yeah, that's a great question. It's kind of, let's see, it's sort of a spectrum, if you will, in choices from great management to general anesthesia on the other side, and everything in between of what you had mentioned. So when do you make that decision? First of all, in medicine, it's do no harm, do no harm. So if the patient is healthy, that's one thing. If they're healthy, then they have a lot of options. But unfortunately, a lot of times the population doesn't get properly diagnosed cardiac wise and other conditions. And that could be dangerous, anesthesia, someone that
Mhm,
has cardiomyopathies or they have enlarged hearts or whatnot,
mhm,
they may need more monitoring, for instance, after the anesthesia to
mhm.
make sure things aren't dangerous. So when we do think we do a triaging system, is there enough dental pathology, and is the dental pathology of grave urgency? In other words, are they abscess teeth or are they small cavities? If they're small cavities, I would invest in the energy of trying to desensitize and paint the silver diamine fluoride and develop a relationship and do the fillings without having to numb up a person.
Mhm.
And it may take a couple appointments to do so. If it's someone that has a swollen jaw and we need to take care of it right away, it's more of an urgency. And I would lean more towards the anesthesia, either in office or in hospital. So the choice between the in office or the hospital would basically be what's safest for the patient in recovery.
Mm.
If they're going to go to sleep and they're kind of thrashing around and they're not safe and they can hurt themselves, then I prefer them to be in a hospital where they can be managed by multiple people that are trained in different disciplines as well.
Hmm.
Uh, and if it's very little work to be done, then it would favor towards an office. If there's a lot of work to be done, if I have to do 10 fillings and 5 extractions and a root
Hmm.
canal, that kind of procedure lends me to feel more comfortable in the hospital where I have more of my equipment available and ready, and different hands on deck, if you will. So the more complicated,
Okay.
the more unhealthy to me would go towards the hospital side. The less
Mhm.
complicated, I would try to desensitize. The ones in the middle are the ones that are kind of in between, that they need to have it done sooner than later, um, and can't afford the desensitization period.
Right. Yeah, I think my son was always in the middle.
Yeah,
He when he was young, he was in a program that's called ABA, and it's like
yeah,
a kind of
applied
behavior
behavioral analysis.
modification program.
Yeah,
Right. But he was in a program back in the day when they would give candy as a reward for
I
doing
know.
a task. And
Guilty.
that wreaked havoc
Yeah, I know.
on his teeth.
Yeah,
And so it started there, but then he started chewing rocks. He would
yeah,
chew anything, and not just rocks. He
right.
would bite anything, and it just chipped away at his teeth, and so he had these little cavities, he had these little chips, all these little things, nothing grandiose, no big abscesses or anything, but, definitely too much for, kind of local anesthesia or some management, and not enough for hospital. So that's why we had porta anesthesiologist,
Yeah,
in the dental. But I've come across cases where you need extensive work, right? You've deferred dental care for 10 years, right? And people have ended up in the hospital. And I don't know exactly how that was all paid for here in California, but somehow it was. Um,
mhm.
so are there any like websites or resources? Let's say you're a parent, you're really struggling with your adults, with autism and their dental care and their dental needs. Where could people go to find practitioners who might take their grown children? Again, it's less of an issue, I think, of pediatrics. It's mostly for the older. Um, the older kids and
Right.
adults.
I think like everyone else, like looking for a good restaurant, you have to ask the right people, right?
Yeah.
So, in every area community, there's a dental society. And the dental society usually knows certain people who are able and willing to see patients that have more medical compromise.
Mm.
So I would think the Dental Society is a good resource. If you're fortunate to live close to a dental school, the dental school is often a good resource to ask, and they might know faculty or faculty practice that sees patients that are a little more advanced medically or special health care needs. There's not a lot of like 1-800, special needs dentists that you can call upon. And I wish there
Yeah.
were.
Mhm.
That we are trying to work with this company called Branchly, who is trying to network different providers, dentists, physicians, and whatnot, different, occupational therapists, physical therapists, to be on a list that they can, at a glance, Google the zip code and find out everyone who provides care for adults and children with developmental disabilities. But
Mhm.
that's in the near future, and not readily available. And they're starting out in Texas right now, but it's a piloted project, and it sounds like a great idea. The regional center, if you're in California, usually knows 1 or 2 names that you can call upon.
Mhm.
But the pediatric dentist folks, they know some adult dentists that will see patients if really necessary.
Yeah.
So,
Okay. Yeah, no, that's all good. That's all very good advice. I found our dentist again, like you said, through word of mouth. There's a dentist, her name is Dr. Sika, who's here in San Jose,
sure.
who sees a lot of patients with challenging behaviors. And really thank God for her. Thank God, because
Right.
you can't walk into any dentist with my son and you know, um, get help. So yeah, you're right. Anyway, is there anything else? We're going to wrap it up. Is there anything else you wanted our audience to know about, accessing dental care? Any other tips or tricks or advice?
Well, I think we start with the prevention, and we start thinking about who's going to take care of my child who's going to be the adult soon, and encourage the pediatric dentist to work with you to finding who's going to take care of my child as they're getting older early. Just like everything else, don't wait till it's a crisis. You might have to start thinking about it when they're 14, 15, 16 years old, before before they became an adult, to get them into your office, for instance. And I like to have um, the patients and parents ask their own dentist, do you see people with special health care needs? And if they say yes, God bless you. If they say no, you say, well, why don't you? There are courses in this. And I would say you have to be a little bit more um, vocal for those who don't have a voice, and say, well, why don't you take some courses, and I can help you. And if you can be part of the ambassador to that, I don't know if any dentists have been asked, why don't you? And
Mm,
if the dentist has been asked more than once or twice or 3 times, why don't you? Maybe it might create kind of a stir. It's like, I don't know, why don't I? Especially since it's an ethical decision that the American Dental Association has said that we as a profession should be treating people with disabilities. And it's against the ADA code that we don't. And until we have people who are properly trained in dental schools, we still need to have people who are out in private practice right now being
mhm,
willing to see patients. So just like you have Dr. Sika, bless them, but we
mhm.
need to grow more people like that. And you can say, if you don't see patients with special needs, why don't you talk to my friend Dr. Sika, that can help you with this? So I think we have to be more vocal about things. So that's my challenge to your audience, to create that grassroots kind of conversation,
Mhm.
and hopefully someone might say yes. If you get one yes out of 10, well, we're making great headway. And we're not asking people to see every patient in the hospital. No, we're asking people to see them in a family practice situation, whether it be a simple fluoride varnish or cleaning or silver diamine fluoride. Every little bit will help me, because that means one less person on my list to see the hospital.
Yeah. Yeah. Let's keep our kids out of the hospital if
Yes,
at
do
all
that.
possible. So remember to brush. I use my spinny brush,
Yeah,
floss. Do you think people should be using water picks
Water picks are
for their
fine.
kids?
A lot of times it's a sensory thing for a lot of the patients, so they don't really care for that too much.
Mm,
But if I can emphasize once again, fluoride varnish for high-risk
mhm.
patients need to be done almost every 3 months or 4 months.
Okay.
If they're high risk, that's kind of an important thing. And if dentists are not using fluoride, they should sort of bone up on that and think of that as a strategy, because it's a non-invasive strategy, just that's a win-win for everyone. If I put something on and it stops the decay from growing, then it's like putting out a fire before it becomes
Mhm.
a wildfire. It
Yeah.
just great help with, you don't have to numb up a person. It's really a win-win for a lot of patients.
God, you know what we really need? We need like a dentist who will come to these like autism schools. I mean this like literally, and just spend a day there, like looking in all the kids' mouth. You know what's really interesting is the schools have kind of an optometrist. They come in
Right,
with a device and they test all the kids' eyes, and you'll
right,
get a report on your kid's vision,
sure.
right? I'm like,
Mhm.
oh my gosh, wouldn't it be amazing? Wouldn't it save everybody so much grief if they had like dentist day at the school and everybody got 10 minutes to open their mouths, not x-rays or anything,
Right,
right? And
right.
get like a little report and recommendation or fluoride varnish or whatever you can do right there. Boom, boom, boom. Oh my gosh. I think
We
I've
we
just come up with my next public health quest.
we were doing that with
Oh
Special
yeah?
Olympics. Yeah, with Special Olympics, that's what we do. We do a quick
Oh
cursory
yeah, with
exam and
Special
do
Olympics.
fluoride
Yeah, yeah,
varnish.
yeah.
And so we're doing that, and we need to do more of that. So yeah, it's something that's important. It's a great public health need. And then we have people that are anti-fluoride. So we gotta to help our friends that are anti-fluoride people understand that in certain amounts, it's very, very safe, and it has reduced the size of cavities and the number of cavities for a lot of populations.
Yeah, I think for our population, they have other things to worry about
Yeah,
aside from fluoride.
true that.
Yeah, fluoride dose, but, yeah, I hear you. Okay, Dr. Wong, thank you so, so much,
You're
and,
welcome.
really appreciated having you twice on our podcast, and I know we will definitely stay in touch, and I really commend you for all of your efforts there at UOP in improving access to care and in training the future dentists of America, and for all, the community work that you do. So thank
Thank you.
you. And,
Thank you
I
very
hope
much.
to meet you in person someday when I'm
Soon,
up in your
soon.
neck in the woods. Okay.
Okay, and I'll send you that link. It's very interesting, and maybe you can share it with your audience in terms
Yes,
of incentivizing oral health care for adults.
I would be interested in reading that
Very
truly.
well.
So thank you. All right.
You're very welcome.
Adios.
Take
Bye.
care. Bye now.